It's called pain.
All right. On that note, let's talk about pain and pain management. So the first thing we have to do is define pain. Now, this turns out to be really difficult. So what do you think pain is? Discomfort. Okay. Say?
Ow.
Ow. All right, what else? Now you've moved too far over.
Just pick a spot, I'll say.
That's 2 over.
Oh, really?
All right, so pain is generally defined as a negative sensation and perception that also involves emotion and other stuff. So first we're going to go over what's called the medical model of pain, and then we're going to go over newer research that shows that it's more complicated than that. So the general steps of pain is we're going to draw our little alien. Oh yes, the alien. All right, so let's imagine that something happens down here, maybe gets hit by a hammer, or maybe gets a bee sting, but there's some event that stimulates a pain receptor. What's the fancy word for a pain receptor again?
Nociceptor.
A nociceptor. So the nociceptor is stimulated, and that then sends a signal up to the spinal cord. And in the spinal cord, there's a synapse. Oh, okay. Nociceptor. And what is the root word for noci in this case? Noxious. All right, so there is a synapse, and then we send a signal up into the brain. And then in the brain, there's some processes that occur, and then we send a signal back down to the synapse. And that signal says either, shut up you lazy bum, or hey, tell me more. So the 4 steps then, step number 1 is transduction. And there's 2 terms we'll have to talk about with that. Then we have conduction, which is the nerve transmission itself. So the receptor being stimulated is transduction. Conduction is the nerve sending that up the pathway. Then the next 2 are kind of together, and that's perception and modulation. So modulation is when the brain sends that signal back down to modulate the signal that's being sent up to the brain. Does that make sense? Now, do you have to have all 4 of these components in order to have pain? No. How many of you were spanked as a child? How many of you ever had this experience? They're like, okay, bend over, we're going to spank you. And you're like, ow! And they haven't even touched you yet. And you weren't just saying ow, it really hurt. When you guys get into the clinical, you're going to be starting IVs sometimes or giving injections. And some patients are like, ow, it hurts, it hurts. And you're like, how many ever heard of phantom limb pain? What is that? You chop off part of a limb, and then they feel pain where there's no arm. Can there possibly be a nociceptor being stimulated there? Okay, so you can actually have pain perception without having all 4 steps. In addition to that, the perception and the modulation are highly regulated by cues. What's a cue? A signal. Something in the environment. Your mood. Now here's the other thing. The perception of pain will also influence your mood. Does that make sense? So pain is really complex, And this very simple model, it actually used to just stop at step 3, is referred to as the medical model of pain. So you got injured, signals are sent up to your brain, you perceive that as pain, then that's it. And as it turns out, it's not that simple. So let's break down some of the things that we need to think about along the way. So the first one in transduction. First of all, you have to have a stimulus. But it's not enough just to have a stimulus. What do you need? Okay, it needs to activate nociceptors, but in order to activate that nociceptor, how much stimulus is the key? So imagine for a moment that we took a sharp needle and we rested it on your skin, just resting. And it's a very light needle. Does it hurt?
Yeah.
Well, it's hurting Ashley. And then we begin to apply a little bit of pressure. Does there come a moment where you're like, ow? And up until then, it didn't really hurt, right? So you need to overcome a certain level of something before you get the pain. And that level of whatever it is, stimulus, is called threshold. Women typically have a higher threshold than men.
Yes.
You don't even feel the pain.
Oh, because of
Yeah.
labor.
Your body's designed for labor. Now, that's an interesting point because different stimuli can have different thresholds. Threshold also happens to tend to change with hormonal balance and with mood and across the day. So we typically have a higher threshold in the morning than we do in the afternoon. So even though 2:30 is a really convenient time to have your dental appointment, 2:30.
2:30.
Yeah, I knew someone who they always set their appointment for 2:30 so they wouldn't forget when it was, because that's 2:30.
I got that.
But from the perspective of threshold, you're better off doing it in the morning.
No, don't.
Okay. If the shoe fits. All right, so that idea is threshold. When we get to the conduction, blah, blah, not a big deal. We're going to break down conduction in a bit more detail when we talk about anesthetics, local anesthetics. So we'll talk about that at that time. Then as far as the perception goes, some of it is learned. It's cultural. It has to do with your family. If you come from a family that's very expressive, you're more likely to experience pain at lower levels of stimuli. Another thing is expectation. How many of you love massages? How many of you? No, massages hurt. Yeah. Okay. Same thing is happening, rubbing those muscles, but in one person is like, oh, that hurts. And another person is, oh, that feels so good. Now, if someone was pushing you that hard outside of the context of a massage, would you experience that as pain, perhaps? Yeah, if someone like wrestling with you and they're like putting you like, and you're like, ow, that hurts. But in the context of this is supposed to be relaxing, you're okay with it. So now I'll give you a little example of how this can play out in real life. So there is a condition in shoulders that's known as impingement. So in some patients, they can't, everyone try this for a second. Take your arm like this. And now try and lift your elbow higher than your shoulder. No, your elbow. Can you do it? It's kind of hard, right?
Yeah.
Okay. So as it turns out, anatomically, it's very difficult to do that. That's called impingement. And you can put someone into impingement by holding the shoulder down and pulling up on their shoulder. Now, some patients, for whatever reason, the way that the bones come together from the chromium process in the clavicle kind of naturally impinges on their shoulder and they'll experience pain, especially doing that. So that's called shoulder impingement syndrome. It never existed until the 60s when there was a surgeon who was examining cadavers and he noticed that some of them, the tendon was being kind of impinged by the bone there. But it didn't happen on all of the cadavers. So he came up with this idea that some people had impingement. And so he made this surgical technique where you kind of like shave down the bone and you relieve the impingement. And then he tried it on people, and guess what? Shoulder pain got better. So what was the message that was told to these people? You have a mechanical problem, there's a bone pushing on your tendon, and it's trapping it. What we have to do is we have to fix that anatomical problem with surgery, and when we do, you're going to get better. And so they did, and what happened? A lot of the times they got better. So now, years later, other people are like, I'm not so sure about this. But in the meantime, physical therapy, surgery, the world has adopted impingement as a thing. But then some people started thinking, well, is there really good evidence to show that this actually works? Well, what would happen if we just gave them physical therapy? Well, as it turns out, physical therapy is pretty much terrible for these people. For the vast majority of them, it doesn't work at all. So then they said, all right, well, what would happen if we took them and we cut their shoulder and we stuck a little camera in there and then pulled it out and sewed them back up and told them we did the surgery? They called that a sham surgery. So they did a trial where they had one group of people got physical therapy, one group got impingement surgery, and one got a sham surgery. The people who got the sham think they got the real surgery. Guess what? The sham surgery is just as good at relieving pain as the real surgery. What does that tell you? It tells you that a large portion of their pain was related to their expectations. Now, what if instead of telling them, you have an anatomical problem that can only be fixed by surgery, you told them, we're not really sure what causes it. In a lot of patients, if you do these exercises, you could get better. The story in their head changes, and then that allows them to do better. Does that make sense? So, how many have ever heard this term before? Placebo, what is it?
Mind over.
It's not mind over matter.
Is it like mental though? Like,
Nope.
It's like when you think that you're getting.
Nope. Oh, say again?
It's when you like when you it's like an experimental trial. It's pretty much when you're pleased, like saying like you're getting whatever it's just like drug or therapy done, but you think that you're getting the actual procedure done, but in reality like you're not.
All right, so it's a term that comes from research, and the idea is if you compare a treatment to a not treatment. But in order for this to work, the patient can't know it's not the treatment. So they think they're getting the treatment, but they're not. And what often happens is you see an improvement in both groups of people. So let's say that these people improve by 30%, and these people improve by 15%. This is not 30% better than no treatment. It's only 15% better than no treatment, or placebo. Now, what is the key behind placebo? They have to think they're getting it, or at least not be certain. Yeah, there's a chance I might get the real thing. There's a chance I might get the placebo. I don't know. So I'm just gonna have to assume I got the real thing because I feel better. Now, can you do the opposite of that? If you tell someone something is going to hurt, will that make them hurt more than if you didn't? And the term for that is nocebo. So the idea behind this whole idea, the idea behind this concept is that when we approach patients, we don't want to nocebo them in such a way that they have to experience pain because that's what we've set them up for. Does that make sense? Now, one of the most difficult things to deal with in our medical system is chronic pain. Chronic pain is just incredibly difficult to treat. We'll talk a little bit more about that later. But one of the things you often find is that patients with chronic pain have a tendency to do less and less and less. Imagine for a moment that your shoulder hurt every time you did a certain movement. What would your parents tell you to do? Don't do that movement. So what happens over time? You end up in frozen shoulder where your shoulder can't do anything at all. If it hurts every time you walk, what do you have a tendency to do less of? Walk. Now, when you're not walking around and active, what does that do to your brain? How many of you had to stay in bed all day before? How do you feel? Crappy. And it can make some people depressed, right? Chronic pain by itself can lead to depression, but then the decreased movement can lead to depression. And the decreased movement, anytime I move, it's going to hurt. I'm expecting to hurt. What is that? It's a nocebo effect. One of the things that you as nurses will do to patients their very first day after surgery is you're going to tell them, hey, you got to get up and walk. And you know what they're going to say? Are you insane? I'm broken. They've noceboed. And you're going to say, yes, you can. And you're gonna. And I'm going to make ya. And you're going to get them up and walk. And it's going to hurt like heck. But you know what? They're going to get better much, much quicker than if you don't. So we have to help patients not accept nocebo. Now, another interesting thing that happens with chronic pain patients, this is not all the time, but some of the time, if you put them on a strength workout program, squats, deadlifts, that sort of thing, in a few weeks, like say they have chronic back pain, in a few weeks' time, sometimes they'll report that their pain is less. And sometimes a couple months later, they're like, you know what, I just realized my back pain is gone. Now, sometimes they still actually have it, and if you really delve into it, they still have it, but they no longer have limitations before. Before it was like, oh no, I can't do that, it'll hurt my back. Oh no, I can't do that. Oh, I can't walk this way. Oh, I gotta be really careful. But through that training process, they've expected, it's a little discomfort, but it's not bad. I can work through that. And what they've discovered is that they are stronger than they realized. It's not necessarily about the muscles getting stronger, so much as it about their expectation of what does and doesn't hurt.
So are they kind of like pushing their threshold?
Well, it's not necessarily related to transduction. It's more related to perception.
But the perception of their threshold. That's what I'm trying to say.
Well, but the threshold is a very technical definition. Anyway, but yes, I mean, something is happening. Now, the amount of pain you can stand is typically called tolerance. So how many of you have ever been told this by the dentist? You might not need some pain medication, but or some lidocaine, novocaine, but if you do, just wave your hand and we'll stop and give you some.
Yeah,
And you're like,
that's annoying.
yeah, and you're like, yeah. So, so there's a moment that you're like, that is too much, I can't deal with that anymore. That's kind of the idea of tolerance. So how much pain can you stand before it's like, ooh, that really is pain. So maybe they're building their tolerance. Maybe it's just about expectations. Think about a little kid who's diagnosed with diabetes, and they've got to start giving themselves injections into their abdomen every day. How many of you have ever gotten a shot? When you got a shot as a little kid, what was it like? It was like the end of the world. No, don't do it, it's gonna hurt. Ah, that's a needle. And then as you get a little bit older, you're like, okay, get the shot. Not bad, that didn't hurt at all. And then sometimes there's like, if you got a nurse who's really good, it's like, did you give me the shot yet? They're like, oh yeah. Now, the medication has an influence on that. Certain medications hurt going in, but it's not the needle that hurts, it's the medication. So you can stab a needle into a person this far and they don't even feel pain if you do it well. What about people who do acupuncture? Yeah. So a lot of it has to do with expectations and context. And so what we want to do is put our patients in the best possible place to give themselves a context of, I am going to be better and I'm not going to feel pain. And that doesn't mean they won't feel pain immediately, but it means they'll be able to work through that pain and eventually it'll go away because they expect it to go away. On the other hand, if you expect to be debilitated and you expect to feel pain for the rest of your life, guess what's probably going to happen? It's probably going to come true. So this is like relatively new areas for pain research. So we don't know all the specifics, but we know some things, and we're beginning to learn more. So, on that note, let's talk about some more specifics of mechanics of pain. So the first thing we need to talk about is acute versus chronic. In acute pain, you have an acute stimulation of that nociceptor. Maybe you got run over by a car, maybe you got hit in the face, maybe you got a sunburn, maybe you got stung by a bee, but there is some event that occurred. And that is the direct cause of your pain. Does that make sense? So acute pain is most often accompanied by a sympathetic response. So what is a sympathetic response? What mediates it, first of all? Okay, it's fight or flight, but mediated by what? We were just talking about it not too long ago. It's just above your kidneys. Adrenal glands produce epinephrine, and your nerves are stimulated to secrete norepinephrine. And so you have norepinephrine, epinephrine, alpha-1, what happens? Vasoconstriction. Beta-1, what happens? Heart rate goes up. Okay. What happens? What about sweat? Yeah, it often starts sweating. If you ever see someone who's really bad acute pain, their face tends to be very pale. They're often sweaty. They look like they saw a ghost. It's like, what is wrong with you? Have you ever seen someone like that who's in a lot of pain? Maybe someone has kidney stones, for example. It's like, and the cold sweat. Okay, so all of that goes into the sympathetic response. So patients with acute pain, especially severe acute pain, what do you expect to see? Sympathetic response. So pallor, diaphoresis, elevated heart rate, elevated blood pressure, and they often have guarding. What is guarding? It's like, don't move that thing. So let's say that you let's say you hurt your elbow really badly. So what do you tend to do? Rigidity around it to immobilize it and prevent it from moving. That's called guarding. Chronic pain, on the other hand, is typically pain that has been around for about 6 to 8 weeks. There's no longer necessarily an identifiable cause. Does that make sense? So there could have been originally, but now there shouldn't really be a cause of it anymore. And chronic pain, patients will typically lose that sympathetic response. A patient who's in acute pain, they're going to look like they're in pain. A person who's in chronic pain might tell you, my pain is a 10 out of 10. And what do they look like? Normal. And so what's the tendency to think about them? They're lying. They just want drugs. And that's an unfair assumption. So an important thing to remember when you're dealing with a patient with chronic pain is that you can't feel or see their pain. So what do you have to do?
Take their vitals.
You have to believe them. Or not. But I mean, those are your only two choices. You either believe them or you don't. So we need to work hard at establishing rapport with patients and a history with patients so that they are more likely to tell us the truth. And so that we are more likely to accept what they say, which is one of the reasons why it's really scary when a chronic pain patient has their doctor retire or if they move to another city, because now they're with a new doctor who doesn't know them, who doesn't have a reason to trust them, and it's like, what if they're just lying so that I'll give them opioids? There's an opioid epidemic, you know. So that can be very scary for a person with chronic pain. Another distinction that we have in terms of pain types is visceral versus somatic. So, how many of you have ever hit your thumb or finger with a hammer? Somatic pain. How many have ever gotten kidney stones or gallstones or some other internal problem. So if the pain is being caused by an internal organ, that's typically called visceral. And visceral pain is typically more difficult to deal with than somatic pain, because your body isn't really designed for the somatic pain. Now, I'm going to say a very controversial thing. For visceral pain. Yeah. I'm going to say something very, very controversial in a room full of women. Kidney stones hurt worse than labor and delivery. That is impossible, Dr. Heyman. You are not a woman. You do not know. Huh. Well, okay, that's fine. I mean, I have had kidney stones and I haven't had a delivery, but I know women who have both given birth and had kidney stones. And you know what they say? All of them say, kidney stones hurt worse. Want to know why that is? Because your body is designed for delivery. It's not designed for kidney stones.
I think that's the mental, like when you're excited for delivery. I think that has to hurt more. But like, because of the perception.
Well, I mean, there is a perception to it, but it's just the nature of that type of pain. Visceral pains hurt worse than somatic pains, and labor and delivery is a somatic pain. What can you say? So, back to our story. Theories of pain. There's a couple different theories of pain. One of them is called the summation theory, and it's the idea that you have to have enough stimulus to actually trigger pain. And the example that I would use is if you've ever dated someone, and what do you do when you first start dating someone? What's like that first little sign of affection? Holding hands. And it's just so exciting to hold their hand. Oh my goodness. And then they start doing this. And at first you're like, oh, that's kind of cute. And then you're like, you know, that's kind of annoying. And then you're like, would you stop that? It hurts! Can you relate to what I'm saying at all? That, you know, you might have a No, you can't at all.
I don't understand how that turns into
Pain, yeah. I don't understand either.
I know my mom used to do this, and once rubbing for a while, it starts getting really annoying.
Well, but eventually it could actually hurt.
My mom.
And then also the idea, like with a massage, if you do the massage hard enough, there's a moment where you're like, it hurts, but it's good, and then it's bad. So that would also be an example of the summation theory of pain. Then we have what is known as the gate theory of pain, and the gate theory of pain is based around this idea right here in the synapse, that when you have conduction of signals up to the brain, there's only so many signals that can go through that synapse. So if you introduce competing signals, you will inhibit the pain signal. An example of that, all right, how many of you have ever crushed a finger in a doorway or by a hammer or something else? What's the very first thing you do?
shake it.
You shake it and you put it in your mouth. Ah! What are you doing? You're introducing competing stimuli that are competing for the pain. Actually makes it feel better, right? One of the things that nurses used to do back when they had time is for all their patients, they would give them a back rub after dinner. And so, first of all, there's incredible power in the human touch. But also, you're stimulating large amounts of skin with non-painful stimulus. And that helps to reduce a person's pain perception and encourage relaxation. Does that make sense? When you guys get to the end of your health assessment course, there's a little section on spiritual assessment and on, developmental assessment. In the spiritual assessment part, we actually talk a little story about a guy who had a surgery and the pain that he felt afterwards, and how it impacted his spiritual well-being, and how having a different attitude changed his perception of pain. So in addition, your mood and expectations can have a vast impact on how you feel. Now, one thing we have to mention is that when a person is feeling pain acutely and they have a sympathetic response, how do you think they might react emotionally speaking? Snappy. Yeah, a little hangry. Yeah, that sympathetic response can make a person more irritable. And if someone's in pain, things that might not ordinarily bother them more. So not only does it affect the physical, it affects the mental and potentially social and even spiritual dimensions. Someone who's in pain might be a little angry with God. Why have you done this to me? Why have you done this to me? Someone who's in chronic pain can feel that too, but they don't have the sympathetic excuse anymore. There's one more thing I was going to mention. Oh, and mood. So laughter and music have been shown to decrease pain ratings. So if you can have a person do something enjoyable or something that's funny, then, or just enjoy something, that can take their mind off the pain. How many of you have ever been involved in sporting events? Have you ever hurt yourself? But you were like, no, I can do it. I'm going to play. And you kept going. And it wasn't that bad. And then the next day, you couldn't move. Or, yeah. So back when I was a bit fatter than fitter, I was like, I used to do boxing when I was young. Let me do some boxing. So they have the boxing boot camp things, whatever. And I'm like, yeah, I'll do one of those. Groupon, okay. So I went the first day, and I was like, I don't really have any shoes that are appropriate for this anymore. Maybe I should get some shoes. So I bought some new shoes and we were there the first day, and the shoes were like on their mat. And they're like, okay, we're gonna do a burpee and you're gonna get back up and you punch, whatever. And so I got down to the burpee and my shoe went and I sprained my big toe.
Oh my gosh.
Like 5 minutes into the workout. Hurt like heck. But you know what? It's not that bad. I can still, limp to the car. See you guys next week, man. Next day, couldn't walk at all on that toe. It took like 3 weeks to get better. But that day, in the moment, with the focus of the workout, it's not bad. It's a little bit, but okay, I can do it. So some of it is your expectation. Does that make sense? And also your drive and your motivation. Sometimes wives will be like, well, look at that sporting person. They had a flu and they played the whatever, and you won't even go take the trash out. He's got a $21 million contract on the line. I got nothing. So anyway, and a lot of that has to do with how you try and motivate a man. This is beyond the scope of Pathopharm, but just for the moment. Generally speaking, men tend to run on respect, whereas women tend to run on love. So when the woman says, how come you don't do anything around here? What she's really saying is, if you love me, you would do things around here. But he didn't perceive, I want you to be my hero and do stuff around here. What he perceived was, I don't respect you. You're a slob. So the way to get the man to do what you want is to be like, honey, you're so good at that. I love it when you do that for me. Could you help me with that? Oh, sure, I'll be your hero. I'll do that for you. What was that?
You said so much time wasted.
I mean, that's just so much more effort. It's like, can you go do that?
Yeah, but it's the difference between marital bliss.
Anytime soon.
It's the difference between marital bliss and, not. Have you ever heard of the crazy cycle?
No.
All right. So the crazy cycle is when, it doesn't matter who starts it, but in this case, we'll start with the husband. So the husband is unloving towards his wife. That triggers disrespect in her, which triggers unlovingness in him, which triggers disrespect in her, and so it's like this cycle of very, very common in marriages. And the thing is, it's just the most natural thing to do. So you really have to try hard not to do that. True story. All right, back to our story. So, pain. I think we've covered all the stuff we need to talk about pain before we get to actual pain management. So, with pain management, first thing we have is non-pharmacological measures. And we already talked about not noceboing patients. That is critical to the idea of pain management. Now, this can be a little bit difficult because one of the things we have to do with nurses is you have to guide them into what to expect. So after surgery, guess what? It's going to hurt, right? And it's okay to say, look, chances are after surgery, you're going to have some pain. But and you're going to feel what you might feel like you can't walk. But guess what? You can. And you're going to, and that's going to help you get better faster. Does that make sense? So you're empowering that person and you're giving them a story that moving through the pain is going to make me better, right? But giving them the story of, this is going to hurt. It's going to hurt so bad. It's going to be the worst pain you've ever had in your life, and you're not going to be able to move. What is that? What story is that sending them? That's sending them a negative story. I don't have the power. The pain will control me. And so what we have to do is we have to put power into the patients. Give them the power to be able to overcome the pain. Don't give them a story that the only way to get out of the pain is surgery. Because as we've seen with the impingement, now it might be true, but it's not always true. So we don't want to give them the story that in their head there's no escape from their pain. Does that make sense? Okay. So that's the first thing. Then non-pharmacological treatments can include gate theory of pain remedies like you can either squeeze, let's say they hurt this side, if you squeeze the other side so hard it hurts too, well, they'll forget about the first side. Not the most effective. You can give back rub. You can do, just setting change. So opening the blinds, getting them up in bed, helping them to feel more like a normal person. How many of you have ever been like really sick and you didn't groom at all for like 2 or 3 days? And then one day you're like, I need to like take a shower and like get dressed and do my hair. And then all of a sudden you feel like a more normal person, even though you're still sick and you don't feel good. And so doing those activities of daily living can be very helpful in helping a person to maintain their pain. Other things include, we talked about art therapy, music therapy, humor, even aromatherapy can be helpful. Spiritual maintenance is extremely important when it comes to pain. So all those things would be considered non-pharmacologic. Now, when it comes to pharmacologic, here's where we get to the fun part. So the first thing we have to do is we have to take a little bit deeper look at the conduction portion of nerve transmission. So, tell me what the parts of a neuron are again. All right, so you got an axon. Axon terminal. Cell body. What are these little guys? Dendrites. Now, this is the traditional, I call this the thermometer version of a neuron, but not every neuron looks like this in terms of scale. Some of them have very long dendrites and short axons, whatever. But the important thing is that we have to send a signal from down here all the way up through the axon. We've already talked about what happens here at the synapse, which is we release what? Neurotransmitter. But what tells the neurotransmitter to leave in the first place is a signal coming down. And what kind of signal is that? Well, that's the name of it. What kind of signal is it? Chemical. All right. So, a chemical, not exactly. It's an electrical. Which is why if you connect an electrode up to a patient's nerve, it'll stimulate their nerve. So, now, I don't want you to think of this as a neuron. I want you to think of it as a nightclub. Now, if you have a nightclub and you want to attract guys to the club, what do you need inside the nightclub? Women, girls. So in the case of the nightclub, these are going to be negatively charged proteins. They've got line because they're negatively charged. Now, the guys in this situation are positively charged ions. And we all know the guys come in two shapes. Cool kids and nerds. So, every good nightclub has a bouncer. And you're going to bounce the nerds out, and you're going to let the cool cats in. So what happens over time? Only the cool kids are in, and all of the nerds are out. So, now, those nerds want to come in because of the electrical charge. They're attracted to the electrical charge. And they're not allowed to come in, so there's more positives on the outside than you would expect. That means that the inside of the cell is negatively charged. And what's the outside of the cell? Positively charged. So that sets up a polarization. Now, if you look up here for a second, I chose this hand motion very specifically. It's a polarization. Why is that? Why did I choose that? What's that like?
The arrow.
So what's... Oh, Katniss, right, yeah. So, bow and arrow. How many of you ever shot a bow and arrow? Yeah. Do you shoot a bow and arrow like this?
No.
How do you shoot the bow and arrow? You're going to like pull it back and it's like a muscle workout, right? Okay. So, how does it take energy to stay right here? Well, obviously, I'm shaking. Okay. So, now what? Is the arrow moving? The arrow is at what? It's resting. But it takes energy to maintain it, right? Okay. These bouncers, takes energy to run the bouncers. The bouncers are called sodium-potassium pumps. So it takes energy to run those pumps. It takes energy to run those pumps in the form of ATP. But we call it resting potential. Why is it resting? The cell isn't resting, it's taking energy. What's resting? The charge is resting. So just like when you shoot an arrow, it takes energy to pull the bow back. The arrow is at rest. Now, does it take energy to let the arrow go? Does it take energy to let the arrow go? Nope. That's a passive process because you have already stored the energy inside the bow. The energy here is in the form of what? What's it called when we have a separation? A difference. A gradient. What kind of gradient have we set up? On the electrical gradient. So we've set this place up, this situation up where there's an enormous amount of tension and that sodium is just trying to get in, but it can't get in because it's being bounced out and the membrane doesn't let the sodium in. So that's the tension. That resting potential is like a bowstring being pulled back. It takes energy to keep it there, but the charge is resting. Now, when the signal gets sent, what do we call that? Not resting, it's action potential. Now, in every good nerd movie, there's a moment in the movie where someone opens up the doors of the club and all the nerds come rushing in, right? And that's basically what happens. We open up a little nerd door that allows the sodium to come inside. And as sodium comes inside up here, that changes the polarity of the cell. The cell begins to become more positive. So we call that depolarization. It was negative inside, positive outside. Positives come in, and that's called depolarization. So what happens is you sweep downwards, little nerd doors opening up all the way down the cell, and nerds coming inside. This step is also known as sodium influx. What does the word in mean? Inside. What does the word flux mean? Flow. So inflow. So the sodium is flowing in, the nerds are going inside the club. And that is what sends the signal all the way down. Does that make sense? So your action potential is caused by what?
Depolarization.
In every good nerd movie, there's a moment where the doors open. What are these doors called? They're sodium doors. Sodium channels. A sodium channel is a nerd door. So the sodium channels open up and allows sodium nerds to come into the club, the neuron. And that's the depolarization. And that's going to sweep down that cell until eventually you get to the end. And then that's what triggers the neurotransmitter release. Now, once the nerds invade the club, what do the cool cats say? This place is lame, I'm out of here. So the influx of sodium actually kicks potassium out of the cell. And then the nerd doors shut, the sodium-potassium pump kicks in again, and you start pulling the cool kids back in as you pump the nerds out. And that repolarizes the cell so that you've got another resting potential waiting to go. Does that make sense? All right, now that we know that, how do you think we could design a drug that blocks nerve transmission? No, that blocks neuromuscular receptors. We want to block the axon terminal from sending a message. If you block sodium channels, you will prevent the signal from being sent. And that's how lidocaine works. Now, lidocaine is not specific to just pain neurons. How many of you have ever gotten your mouth numbed at the doctor's office? In addition to blocking pain, and then you try and eat the food and you bite your tongue, right? And you try and smile and you're like, or if they only numb one side, you're like, I can't move my fingers. So it can also block motor neurons, and it can also block other sensation besides just pain, depending on the dose of the drug. So that's how lidocaine works. We've already talked about what happens when you mix epi with lidocaine, so just remember that. And that's pretty much it.
So at resting, you're negatively charged.
At resting, the cell is negatively charged, the membrane is positively charged.
So when you block the sodium channels, the cell stays negative.
Yes. So when you block the sodium channels, you prevent the cell from becoming depolarized, from becoming positive. All right, so that's how lidocaine works. That one is pretty simple once you understand the whole idea of nerd doors. Okay, good.
When the cell is resting, the charge is...
No. The charge is resting. The cell is not resting. So resting potential is about the cell, is about the charge, not about the cell. And when I was in A&P and all that stuff, I'm like, how come it takes energy to rest? This is stupid. And it wasn't until years later I was like, oh, the charge is resting. So that's your Katniss Everdeen reference. The arrow is resting, but it takes energy to pull back the bow. All right, so that is lidocaine. Next, we're going to talk about opioid drugs. So, opioids work by activating opioid receptors. Now, what is the difference between opioid and opiate? Oid means like, so it's opiate-like. So there's only two opiates in the world, and that is morphine and codeine, because they come from the opium plant, the opium poppy. Everything else that's artificial or synthetic is not an opiate, it's an opioid. Does that make sense? Okay. There are a number of natural opioids in your body. So the two most commonly known ones are endorphins and enkephalins. And they're naturally produced in a number of circumstances. How many of you have ever been addicted to exercise? So, you do this grueling workout, and at the end of it, you're like, I can barely walk. Oh, I'm so broken. And then about an hour later, you're like, oh man, life is good. Everything is good. Peace in the world. I just feel fantastic. And what's happened is you're actually high. So what you're experiencing is sometimes known as runner's high, although I've never experienced that running, but I have experienced it through karate and some other stuff. But running, anyway, they call it runner's high. And what causes it is the release of natural endorphins after exercise. When we stimulate opioid receptors with drugs, you can get much, much higher levels of stimulation, which is going to lead to increased pain reduction. So the number one, now there's 3 different opioid receptors in your body. There's like mu, kappa, and epsilon, I believe it is. And in the notes, it actually talks about which drugs stimulate which things, and not on the test. So what we're going to focus on for the test is the actual physiological effects and the ones that we want to happen and the ones we don't want to happen, and how we deal with the ones that we don't want. So the number one thing that we want, the therapeutic effect of opioid drugs, what is it? Not high. Decrease pain. And what's the fancy word for pain, or prefix or root for pain? Arthralgia, neuralgia, analgesia. So what we want is analgesia, which is, or analgesic effect. So decrease pain. And not get it? Analgesic. Analgesic. Does that make? And not algia, pain, esic, thing that causes. Anyway, forget about it. Reduction in pain, that's what we want. Now, there's another effect that we sometimes want, which is reduced cough. And you can actually, you'll sometimes see people who have an opioid prescription for a cough. So that is sometimes a therapeutic effect, but it could also be an adverse effect. If someone's got a lot of sputum and you're treating them with opioids for pain, that could make them more likely to hold on to the mucus, which in turn might not be that good for their airway. But for the most part, the reduction in cough we could consider a potential therapeutic effect. Sometimes it actually is used for that. The next thing we have is respiratory depression. Now, what does the word depress mean? If you have a button and you push on it, what's that called? If you push it down. Okay. All right, let's imagine you have a button that you push like this. What would that be called? Press. Press. Now, the button is facing this way and you push it down. What's it called? Depress. So to depress means to push down. So when we talk about respiratory depression, what exactly is getting pushed down? It's not the diaphragm. That happens all the time. We're talking about your respiratory drive. So how would a decreased respiratory drive be manifested? What would that look like, health assessment wise? Not tripoding. Fewer respirations per minute. So what's your normal? 12 to 20. So if a patient goes below 12, that's going to be considered respiratory depression. Are we going to do anything about that? Yeah, what? I don't know. The way you asked it, I just knew I had to do something. What are we going to do about a patient who's respiratory depression from their opioid? And the answer is, you're going to hold the next dose. So anytime you give a respiratory drug, an opioid drug, what are you going to check? Respirations. If the respirations are less than 12, what are you going to do? Not give them that dose. But wait, there's more. What happens if their respiratory rate is less than 6? Now what are you going to do? Intubate? You just want to kill a person, don't you?
Call the physician.
Call the physician?
Give more oxygen, stimulate.
Well, the answer is we have to intervene in some way, and we got to raise their respiratory rate. So there's a couple ways we can do that. One of the ways you can do that is by stimulating the patient. You have them get up and walk. Now, for some patients, just like raising them up in bed and sitting them up in bed is like raise their respiratory rate. But for a lot of patients, you're going to have to do more than that. Now, that might not be enough. So what else could you do? Give another drug? What kind of drug? Okay, well that would make their airway open, but it wouldn't necessarily make them breathe more. So not a beta agonist. What's the problem? They're not breathing enough. So what do we want them to do? Breathe more. And what kind of drug would make them breathe more? You're going to hit yourself when you realize what the drug is. Is it what? Say it, say it.
It's wrong.
It might not be.
What is it?
I'll say
Kind of
it.
like next to those, but
Well, yes, those are wrong,
I
sorry.
knew it was wrong. I didn't want to say it.
Well, we didn't know you were wrong until you said it, so there you go. Now you won't make that mistake again. I told you, this drug is so simple. You don't necessarily know the name, but the drug concept is so simple that you'd be like, duh. What's the cause of their respiratory depression? An opioid. So what would we... An anti-opioid. Okay. So an opioid antagonist. And the drug of choice there, well, the drug name you're going to learn anyway, is Naloxone, which I'm sure you have heard of, Narcan. How many of you have heard of Narcan before? One person. Okay. Well, Narcan is the brand name for naloxone, and it's the antidote to an overdose of any opioid, including heroin. So how many of you have seen those shows like where they have the addicts and they're all like, and then they like give them a drug and they're like, naloxone. Now, when you give a patient naloxone and you block you unblock their opioid receptors so that the opioid gets kicked off, what's going to happen to their respiratory rate? It's going to increase. What's going to happen to their pain? It's going to increase also. So what we don't want to do is just give them whatever it is. It says 2 cc's, 2 cc's in there, baby. What do you want to do? A little bit, wait, a little bit, wait, and you want to give just enough. When you give just enough, what is that term? What is the word for that? You're going to give them a little bit, just enough to get an effect. It's a chemical term. We're going to titrate. Yeah, in chemistry. Okay. So you're not necessarily going to slam the drug in there. You might not even give the entire dose. You want to give enough for the respiratory rate to recover, but not so much that the patient is now in extreme pain.
So that's like a big difference, either getting them up to walk or giving them naloxone.
Yes.
So how would you decide which one to do?
I don't know. You have to use your judgment in that situation. I'm just giving you options at this point.
That's like, okay. Sounds good.
Yeah, so in case you didn't hear that, the question was, how do we know to choose between getting the patient up and walking or giving them naloxone? And the answer is, well, you got to make that decision at the time. So.
Is it possible that your body gradually, like, giving them a little better and make them walk as well? Or
Possibly, yeah. And the other thing is, like, if you have a patient who's at 6 versus a patient who's at 1, that's a big difference. So the more gone they are, the more likely you are to use naloxone. Now, most hospitals nowadays, when an opioid drug is ordered, they are also going to order a naloxone dose PRN. So before you go, hey doctor, this patient's got respiratory depression and they're on an opioid, and do you think I could get some naloxone? Well, did you give what I ordered? Oh, let me get back to you. Hold on. You don't want to be in that situation, right? So anytime you give an opioid, you want to also check for the naloxone dose, make sure you know what's there, make sure you know how to give it, all that stuff. With pediatrics, it's much more dangerous. They have a lower threshold for becoming respiratorily depressed than you do with adults. The more someone has taken opioids, so like a person who's been on them chronically or an addict, typically is going to have a much higher tolerance for the drug. So it'll take higher levels of the drug to make them respiratory depressed. Okay, so that is the second adverse effect that we've got here, respiratory depression. Then we have, no, go ahead.
If a person is like an addict, wouldn't it also take more to reach the level of like to decrease the pain?
Yes, quite possibly.
Okay, so that could still put them at the respiratory depression.
Right. Yeah, so you just have to see what you're dealing with. So the next one is going to be euphoria. Now, what does euphoria mean? Eu means good, phoria means feeling. So I feel good. I knew that I would. So nice. Sorry. So in colloquial terms, what would this be called? High. Now, the government does not like people feeling good. So you're not allowed to be high. So that's why we have to not let you have access to these drugs. For your own good, you must feel bad. What? Could you feel bad on these drugs instead of good? How many of you have ever had an opioid drug? Codeine, Percocet, oxycodone, something like that. And you were like, this is awesome? Or were you like, I don't really like how I feel?
It caused me to throw up.
Well, yeah, throwing up is a different adverse effect. But it wasn't that good. Okay. So the opposite of euphoria is dysphoria. And quite a lot of patients hate the way it makes them feel. I don't like it. It is not good. That would be dysphoria. Then we have drowsiness, increased drive to sleep. However, that sleep is not necessarily more restful. So opioids are not a good choice for insomnia. Even though they make you drowsy, they don't necessarily make you more refreshed. Then something that is related to that is mental clouding. Mental clouding can be anything from you just can't think quite straight to your reflexes are diminished and your judgment is impaired, which means that when you are on an opioid drug, you should not operate heavy machinery, aka an automobile, let alone a motorcycle. Does that make sense? All right. Also, got to be careful about potential falls. You know, just in general, you just have to be a little bit more careful. I had surgery once, and I was on an opioid after the surgery, and someone rang the doorbell. I was upstairs, like, oh no, I got to go let them in. I took like 2 steps down the stairs, like, boom, 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 boom. I'm like, how did that even happen? Yeah, your reaction times aren't quite as good as you thought. Your brain processes aren't quite as good as you thought. You just have to be more careful. All right, then we come to Ashley's favorite, which is nausea. And what goes along with nausea? Vomiting. Some patients will always get this with every opioid no matter what. Others will only get it with select opioids. So maybe hydrocodone, which is in oxycodone, which is in Percocet, gives them nausea, but hydrocodone, which is in Lortab, does not. So it can vary by drug, or it can be, it doesn't matter which drug it is, it's all going to cause nausea. Typically, the higher the dose, the greater the nausea. How would you deal with nausea? An anti-nausea medication. What's the fancy word for vomit? Emesis. So a drug that prevents that would be called an anti-emetic. So you would give antiemetics. Now, for the bonus prize, what route do you think you should not give an antiemetic in this case?
Yeah.
PO. Why?
They'll throw it up.
Because you vomit it back up. Now, if you're giving it ahead of time, pre-dosing, can you give it PO?
Yes.
Yes. But if you're waiting until they're nauseated in order to give them the drug, then can you give it PO? No, because they might vomit it back up. What I was going to say there. Yeah, it doesn't matter. Okay, so nausea. Then the next one is constipation. Just slows down your guts. Now, there's a couple things that are important for this. First one is the three main things for general prevention of constipation. Number one is adequate hydration. Water makes stool softer. You need more water to keep your stool soft. Second is adequate fiber. And the third is physical movement. Getting up and walking and moving around will also help. But with a patient who's on one of these drugs, those three things might not be enough, in which case you would need a laxative. Stimulant laxatives are typically preferred, but you could also use an osmotic laxative. Now, don't worry, those terms don't mean anything to us right now, but if you're slowing down the gut, giving a stimulant will speed it back up. An osmotic laxative pulls water into the gut. And then, well, more water in the gut, less hardness, goes out easier. The thing that does not work very well is what's called a stool softener. And the drug there that's typically used is called docosate or colase. If you see that, chances are good it ain't gonna work very well. But for whatever reason, lots of doctors like to prescribe it
Why is
in this situation.
it doesn't work well for softening stool?
Habit,
What do you mean?
that's why they prescribe it.
Out of habit?
Yeah,
Even though it doesn't work.
yeah.
So what would you, like, what, I was gonna say a lot of people get it just over the counter.
Oh yeah, docosate is over the counter.
Is the other one available over the counter?
Yes, all of them are available over the counter. But in the hospital situation, it has to be ordered.
Yeah.
Now, outpatient, you can tell the patient, hey, go to the pharmacy and get some Bisacodal, some Ducalax, and take it every day. Stimulant laxative or Senecot. But in the case of, or you can even give them Miralax, which is an osmotic one. But giving them Colase, it just doesn't work as well. One of the interesting things is, I had a neighbor once who was in a car accident where, he was like one of those people who delivers, like drove a big rig and delivered building materials to road crews on the side of the road. So here's his truck on the side of the road, and like, here's the edge of the road, and here's him talking with this guys, and this car comes like way over on the side, hits him. He goes flying through the air, almost tore his leg off, shattered his scapula, all of this just bad. And here he is, a couple months later. I'm like, where have you been? He's like, yeah, I was in this crazy car accident, blah, blah. And we got to talking, and he's like, and then the constipation, and they didn't warn me. I hadn't had a bowel movement in like a week, and it was hurting so bad, and all this stuff. I'm like, they didn't warn you? I'm like, they didn't give him anything for an entire week. Now imagine that you had a week's worth of poo inside of you. Do you think that would hurt? How many have ever been constipated for like one day? And the next time you go, it's like you thought you were going to die. And then you look in the toilet and it's like smaller than usual. And you're like, I give up. So imagine a week's worth of that. It's like, nurses, you gotta warn your patients. And this is not noceboing them. This is like dealing with reality that, hey, chances are you might be constipated. If you are, we need to do something about that sooner rather than later. Next, we have urinary retention. Now, the way that this works is kind of twofold. The first is, when you go to the bathroom, how is it that you typically initiate the stream? What do? You relax. And what happens? Water comes out. All right. In the case of urinary retention, you relax and Nothing happens. So what you have to do? Got to push. Now, once the stream starts, maybe you have to push a little bit, but once the stream starts, typically it just keeps going by itself until you're mostly done, right? Okay. Well, in the case of this, not only do you have to kind of push to get it started, you have to push to keep it going. Otherwise, it's going to stop. The other thing that happens is that there's just less urge to go. How many of you, if you think about water, it's like, oh, gotta go. Yeah. It's like you're fine until it started raining in the car. And you're like, gotta go. So in this case, though, it's just like, nope, you don't gotta go. So there's two things we have to do really just one thing we have to do for our patient, which is encourage them to go. So I know you might feel like you don't have to go right now, but it's been about 4 hours, and I really need you to at least try and go to the bathroom. And try, don't just, yeah, try. So that would be what we do for urinary retention. Next, let me see if I'm going to move this over here. What?
A lot of side effects.
Yeah, I know. It's like steroids. Only more so. All right, so then we're going to have meiosis. So we already learned about meiosis when we talked about cholinergic stuff. So what is meiosis? Pupillary constriction. And what is that going to do to their ability to see? They need brighter room. But, now this is one of the cases we get into addicts. Addicts who are addicted to opioids, like heroin, will often wear glasses to hide their little tiny pinprick pupils. Makes them look kind of like a reptile. They call it reptile eyes. So they use glasses to hide it, and then that makes it so they can't see as well, so they bump into stuff. So clear the room of things that they could bump into and keep it more brightly lit than usual. Next, we have itching. Opioid receptors are coupled to histamine receptors or something. Yeah, histamine receptors. So when you activate opioid receptors, you also release histamine, get histaminergic effects. So that causes itching. How can you solve the itching? Give an antihistamine. What's the fancy word for itching, by the way? Pruritus. Okay. All right, and there's one more we need to talk about, which is biliary colic. Now, what does biliary mean? Having to do with bile. Now, where's bile made? In the liver. And then it's secreted through a little series of ducts called the biliary tree. And then it collects in the gallbladder. Now, those little biliary ducts, for whatever reason, have little muscles in them. I guess like milks it down, I guess. And sometimes those little muscles go, and guess what happens when you get that? Incredible pain. And that is sometimes triggered by opioid drugs. If an opioid causes biliary colic, there's really nothing you can do to fix them except take them off the opioid. Now, sometimes one drug will cause it for them and another one won't. So you might try switching opioids. But a lot of patients, the only thing you can do is take them off all opioids. Does that make sense?
And that happens at the tree.
And that happens in the tree before the gallbladder. All right. Did I miss any adverse effects from your notes there? I think I got them all. All right. We didn't talk about addiction. We'll talk about addiction after we finish talking about the rest of the drugs. But I believe we should take a break at this moment in time. No, not really. It's time to go in 20 minutes.
Oh, is it really? Oh,
We should just push through.
No, let's just go. Let's just
All right.
Keep going.
I talk too much.
I just stay so passionate years
How do I say so passionate what?
about teaching the same thing each year.
Well, it's new students. It's about the performance.
do a great job, I gotta say. You really do.
So one of the reasons, well, even when I use PowerPoints, I'm like, the PowerPoint isn't the presentation. I am the presentation. So what we're going to talk about next is kind of a throwback to our last topic. What was our last topic before pain?
Blood clots. I mean, not blood clots.
The I word, inflammation. So these are analgesics, but they're also anti-inflammatories. So as it turns out, there is a substance in our bloodstream and various cells called arachidonic acid. We'll call it AA for short. And when you expose arachidonic acid to different enzymes, it can become different products. So there's one enzyme in particular called cyclooxygenase, which we conveniently abbreviate COX. So cyclooxygenase turns arachidonic acid into a group of substances called prostaglandins. And these prostaglandins control a number of physiological functions, including macrophage function, kidneys, platelets, and gastric mucus. When you have inflammation, though, there's a different kind of COX that is released, and that type of COX is called COX-2. And that causes a reduction in inflammation, which also results in lowered pain and lowered temperature. Oh, I forgot something on this side over here. Over here we also have uterine contractions. Okay. So, we can use drugs that block COX-1 and COX-2 to inhibit, oh, I'm sorry, I lied. Increased inflammation, increased pain, increased temperature. So we can use COX, well, our body uses COX to promote these functions. These are called homeostatic functions. And then we can use COX-2 to increase pain, temperature, and inflammation. Now, we have drugs that block COX. These are called COX inhibitors. You didn't think that would happen, did you? So, when you block COX over here, what do you get? You get decreased inflammation, decreased pain, and decreased temperature. A drug that does that might be called ibuprofen, naproxen. How many of you have taken one of those two drugs? You've never taken one? Oh, okay. Whew. For a second, I thought you weren't human there. So, if you have a headache, you can take one of these drugs, helps make the pain go away. If you have a fever, you can take one of these drugs, makes the fever go away, or at least reduce. And if you have inflammation, it can help reduce the inflammation. Now, as adverse effects, it can also interfere with macrophage function, kidney perfusion, platelet function, gastric mucus, and uterine contractions. Now, as it turns out, this would be a therapeutic effect in what situation? No. If you wanted to induce labor, you would give prostaglandin, not block it. In every woman's life, there comes a certain time of the month. Cramps. So, this is the reason why ibuprofen works for cramps and Tylenol doesn't. Well, there's no Tylenol here, but there will be soon. Because Tylenol doesn't reduce COX-1 in the peripheral system. So, this is technically a therapeutic effect, but this is not. Now, Why do we produce gastric mucus in the first place? Because our stomach produces what? Acid. So it can help digest foods. But the acid could destroy our stomach. So it's like chemical warfare against the food, but protect the stomach. What protects the stomach from the acid? Gastric mucus. And what tells your stomach to produce that mucus is the presence of prostaglandins. So when we block COX, not only do we block these, but we also block this. And what does this put our patient at risk for? Ulcers. What kind of ulcers? Gastric ulcers. Yeah. Okay. So, and that can lead to sudden death if you're not paying attention. This is the most dangerous of the adverse effects for most people. Some people can get renal problems, renal toxicity, where they go into acute kidney failure. That's usually with overdose, not with therapeutic doses. And then you can also have increased bleeding risk from platelets. Now, there is one drug that we use in particular to inhibit platelet function. And what is that one drug? You can probably know this already. Just, if you have a heart attack, what drug do you take? Aspirin. So aspirin is acetylsalicylic acid, so sometimes we abbreviate aspirin as ASA. So aspirin is the only drug out of the COX inhibitors that we use to target platelets. In every other drug, platelet inhibition is an adverse effect. For aspirin, it could be a therapeutic effect, trying to prevent what? Sorry. Heart attack and stroke. But generally speaking, the decreased platelet function is an adverse effect. All right. So, yes, ma'am.
So for you're saying that if we block one of those things, it can block all of those things. So
Right. So you give ibuprofen, and it blocks this, causing these therapeutic effects, but it also blocks this, causing these adverse effects.
So would an aspirin could lead to those adverse effects as well?
Yes.
Okay.
But with aspirin, we're targeting this one, as opposed to targeting these ones.
Like ibuprofen.
Yeah. Right.
That's not selective.
Yes. So there are four non-selective COX inhibitors that we need to know for now. There's like a dozen, but we're going to learn 4. So the first one, we already learned it, aspirin. And it's special. We'll learn about why it's special later when we talk about blood clots. But for now, it's special, used for reducing platelets function. Then we have ibuprofen, which we already talked about. You need to know the normal doses for ibuprofen. So ibuprofen usually comes in 200 milligram tablets over the counter, and you can take them in units of, well, 200, 400, 600, 800, 1,000? What's the max safe dose of ibuprofen? It's 800. So 4 of them at one time, and you can do that up to 3 times a day. Alternatively, so how many total would that be for a 24-hour period? 3 times 8. 2,400. Now, what if you did 600 4 times? 2,400. So in total dose, those two are equivalent. So you can either choose every 8 hours, take 800, or you can do every 6 hours, take 600. Then you have naproxen. And naproxen typically comes in 200 milligram tablets, but the max dose is usually 500 or 550. And you can't exactly make that happen with the over-the-counter drug, the over-the-counter the pills. One of the major advantages of naproxen is that it lasts longer, so instead of taking it 3 to 4 times a day, you only have to take it twice a day. However, as a naproxen user, I can tell you that I often have to take it 3 times a day. Do I ever go over the max safe dose? Who, me? What? No. Never. Anyway, Then we have one more we have to learn, which is ketorolac. Oh, man, I forgot something about the opioids. Such a loser. Okay, so ketorolac. Ketorolac is also known as Toradol. And this one is very commonly used in urgent care centers and because we give an IM or IV. And it's also used very commonly after surgeries. Because when you give it IV or IM, it has similar efficacy to moderate steroids. So it produces about the same amount of pain relief as a drug like codeine. So, what's the number one adverse effect you have to worry about for patients who are on COX inhibitors? Gastric ulcers. Now, what if we had a drug that was selective for just COX-2 and not COX-1? Would there be less ulcers? So we actually have COX-2 selective one, and that is called celecoxib. By the way, do you know what IB means? When you see IB in a drug, it means inhibitor. So it's a COX-IB, COX inhibitor. Oh my goodness. Now, there used to be other drugs in this category that you had to learn, like rofecoxib and valdecoxib, all inhibiting COX. But we no longer have to memorize those. Want to know why? Because they caused adverse effects in terms of cardiac function. They caused higher blood pressure and higher risk of heart attack. So they got taken off the market. Celebrex is the only one that has survived. Now, when you take COX inhibitors, any COX inhibitor, there is a risk your blood pressure could go up. And there is supposedly a small increased risk of cardiac events, which means like a heart attack or stroke. But these are still safe enough that they're on the market. The brand name for this is Celebrex. And Celebrex is a sulfa drug. So if you remember way back when we talked about antibiotics, sulfonamides, sometimes you'll have a patient who's like, oh, I'm allergic to sulfa, but they're taking Celebrex. So they're not actually allergic to sulfa in that case. They may have had an adverse reaction to a sulfonamide or some other sulfa drug, but it wasn't a true sulfa allergy. Any questions about COX inhibitors? All right, so now we have to go back in time for a moment and rewind to your opioid drugs, because you know what I forgot to do? Go over the actual drugs.
Oh, that's right.
Aha! So the first one that we have to do is morphine. Morphine was the very first one that was discovered. It's a natural drug. It's found in the opium poppy, along with codeine. By the way, we divide these into strong and moderate. So strong ones, morphine is the first one, and it has all of the effects we talked about earlier, plus has one other effect, which is it causes venous dilation. And that is going to cause a small decrease in blood pressure and a small decrease in the amount of blood going back to a patient's heart. And that actually makes it very helpful for treating some cardiac conditions like heart attacks. It can be given either PO or IV. It's considered the gold standard in that, now we say gold standard, we don't mean the best, but we mean it's like the baseline you measure everything else against. Everything else is either stronger than, more potent than, or weaker than, less potent than morphine. Does that make sense? All right. Then we have one that I believe we've taken off the list, but I just need to mention it, meperidine. Demerol is a completely synthetic form of morphine, but it can cause, and it has few adverse effects in terms of nausea and biliary colic. However, it builds up into a toxic metabolite. When your liver clears it, metabolizes it, it turns into a poison, and that poison can actually damage your liver over time. So you can never have more than 2 days worth of Demerol. So nowadays it's very rare to see Demerol given at all. So Then we have fentanyl. Now, fentanyl has a couple purposes. Inpatient, it's most often used in anesthesia for surgeries. You give them like a fentanyl gas and it puts them out cold. They're before your time, but there had actually been a terrorist event in Russia where these terrorists had taken over a school and were holding these kids hostage. So the Russians pumped fentanyl gas into the building, make them all go asleep, and they can go in, not have to hurt anyone, and they overdosed them and everyone was dead. Now, most of the time, what you're going to see fentanyl given, you're going to see it given in the form of a patch called a Duragesic, and that's for chronic pain only. So you put the patch on, and it administers the fentanyl out over small periods of time for 3 days. Replace the patch with a new one. Next, we have something called hydromorphone. Now, hydromorphone is a synthetic form of morphine that's got a hydro on it. So it's morphine with the hydro is hydromorphone. And that is much more potent than regular morphine. And that is the brand name Dilaudid. So like with morphine, you might be giving like say 2 to 4 milligrams IV. With Dilaudid, you'd be giving like 0.1 milligrams. So you'd be giving an enormously smaller dose with Dilaudid. Now, Dilaudid is also a very clean drug in terms of adverse effects. It doesn't have quite as many adverse effects as some of the other opioids, which makes it an addict's kind of drug of choice a lot of times. And the problem is, over time, if you have a problem where a medical problem where you have to go into the emergency room repeatedly with pain, you kind of learn which drugs work better and which ones don't. And so if over time you've learned that Dilaudid works better for you, the next time you go to the ER, you go like, hey, don't give me the morphine, that doesn't really work. I need Dilaudid. And what does the nurse say? Drug seeking, you're an addict. Unless they have a good relationship with you, in which case they say, oh yeah, I remember the last time you were in blah, blah, and I know you're not an addict, let's go ahead and give it to you. So it's one of these double-edged swords where when you know what works for you as pain management, you're afraid to tell them sometimes because you're afraid of being labeled as drug seeking or as an addict. Whereas if you don't, then they might give you a drug that has more severe adverse effects for you and doesn't work as well for you. It's a crazy mixed up world that we live in. So that's Dilaudid. And then we have methadone. Now, methadone is a very, very long acting. It's like 36-hour half-life. As a result, it doesn't give a very high peak. So there's not a lot of high that's associated with it. So this is very commonly used in detox clinics when you want a patient to stop using opioids, but you don't want to give them withdrawal symptoms. Oh, speaking of withdrawal symptoms, what happens if you stop taking, if you've been taking opioids for a long period of time, what happens? Well, two things happen. One is you need a higher dose to get the same effect. What's that called? Tolerance. And the second is if you stop taking the drug, suddenly you get withdrawal symptoms. What would the withdrawal symptoms be, do you think? Say again? Not necessarily. It's the opposite of everything you had before. So if you had constipation, now you have, if you had urinary retention, now if you had meiosis, now you have mydriasis. And typically they're going to have, what do you call it? I'm trying to think of the word. Stippling of the skin. Chicken skin. What's it called?
Oh, goosebumps?
Goosebumps, yes. Can't think of it. Goosebumps, which is why we call it going cold turkey. Because when you go cold turkey, you get goosebumps on your skin. Anyway, so the treatment for the withdrawal syndrome is put them back on an opioid and then taper slowly. Now, withdrawal syndrome is not a sign of addiction. What's it a sign of? Chronic opioid use. So if you have a legitimate reason to be using it and you stop because now it's time to stop, what can you expect? Withdrawal symptoms. How do you minimize them?
By putting it back on the drug and tapering it.
Taper it. Okay. So that is the strong ones that we're going to learn about. Then we've got codeine, which is also natural and found in morphine. Now, codeine is an interesting drug because if you give it in high enough dose, it'll be just as strong as morphine. However, it will also damage your liver. So we only give it in smaller doses, which makes it moderate, not strong.
Just out of curiosity, what do we actually get into detail, like how much?
How much drug? In this course, we're not really going to go over the doses that much because that's something you can look up at the time that you give it. So there's a few drugs that we are going to definitely learn doses on, like we learned those because they're over the counter and you can use them yourself. But for the most part, that's something that you can look up at the time. We also mentioned normal doses with IV methylprednisolone. Yeah. But since you ask, a normal dose would be about 30 milligrams, PO. Then we have oxycodone and hydrocodone. So these are both artificial versions of codeine that work better than codeine and are safer than codeine. But they got a bad rap. Why is it a bad rap? Because they became drugs of choice for addicts. Now, oxycodone started off first in terms of bad rap because of something called OxyContin. OxyContin is a continuous release form of oxycodone that is meant for chronic care patients. Sustained opioids are only for chronic pain. They are not for acute pain. But if you chewed it up, or if you crushed it up and dissolved it, now you got all of it at once. So oxycodone is usually found in the form of Percocet, which is going to be either 5 milligrams or 10 milligrams of oxycodone. OxyContin came in 20, 40, and 60 milligrams. So if you had 60 milligrams and you crushed it, it'd be like getting the equivalent of 6 oxycodones or 6 Percocets at the same time. Now, Percocet also has acetaminophen in it, which in overdose damages your liver. So you can't take too much Percocet. But by taking OxyContin, you can take a whole bunch of it really conveniently. As a result, it became the #1 target of addicts throughout the country. And so that led to increased controls on it, so it was harder to get. And so then what do people switch to? When you make it harder to get one drug, what do? They switched to another drug. So they switched from trying to get OxyContin to getting hydrocodone. And at the time, oxycodone was Schedule 2, which required a physical prescription. Hydrocodone was Schedule 3, which you could call in. So, hi, hi, this is Dr. So-and-so. I'm trying to call in the hydrocodone for my patient. So one of the things they did was they changed hydrocodone from Schedule 3 to Schedule 2 to make it harder to get. Now, we need to know so there's some mixes, and we need to know those mix names. So we already said when you mix oxycodone with acetaminophen, what do you get? Percocet. When we mix hydrocodone with acetaminophen, what you get is a brand name, either Lortab or Vicodin. Now, you do need to know those names. They will be on your test. The last drug that we're going to mention, and I just mentioned, is called propoxyphene. When you mix it with acetaminophen, you get something called Darvocet. Now, the thing about propoxyphene, it is a very weak opioid. It's so weak that it has very little analgesic effect. And what that made a lot of doctors think is, oh, that's the safe one. Let's give this to our elderly patients who are afraid of giving too much bad adverse effect to. But guess what? It's only moderate in the therapeutic effect of analgesia. It's not moderate in all those adverse effects we were talking about. So it is actually one of the worst drugs you can give an elderly patient because it doesn't work in terms of pain relief, but it works in terms of adverse effects. Eventually, it was on the do not prescribe to elderly list for like 15 years before, and doctors are still prescribing it for elderly folks. And eventually, the FDA said, hey, guys, can we just stop making the propoxyphene here in the United States? So it's no longer been available for at least the last 5 years. But how many of you want to go on mission trips? You can still get propoxyphene in other countries, sometimes over the counter. So you need to be familiar with what it is. And that is all of the opioid drugs. So one last thing I got to mention with the OxyContin thing, because you could crush it and get super high levels. Now, it's meant for chronic pain patients, right? What do your chronic pain patients have that a normal person doesn't? How long have they been taking the drug? A long time. So they've built up tolerance. Now, let's say that grandma dies and little Johnny finds the OxyContin in the medicine cabinet. Oh, jackpot. So little Johnny takes a couple of the pills, crushes them up, drinks it. What do they get? Let's say they took 4 of the 40 milligram OxyContins. 4 times 4. So they're getting 160. Now, how many are in an ordinary Percocet? 5 to 10. So let's say we're dealing with 10. So they're getting 16 times the normal dose. What's going to happen to little Johnny? Dead, respiratory arrest. So as a result of a number of fairly high profile accidental deaths, and then all of the crime that was associated with it, eventually what they did, besides making it harder to get, was they also changed the OxyContin to what's called a micronized form. So the pill was consisting of a whole bunch of tiny little time-released. So when you crush it up, it doesn't actually destroy the time-release mechanism. So for the last probably 8 years now, you haven't been able to get the old stuff that you could do that, crushing trick with. So you crush it now, it's still time-released. So that makes it safer and harder to abuse. All right, on that note, I think we're out of time. We have still acetaminophen to go. And then we'll also talk about addiction and some general principles of pain management next time. All right, see you guys later. All right, welcome back. And last time we finished up, we had just finished talking about opioids, and we talked about NSAIDs and COX-2 inhibitors. So now we're going to finish up our pain by talking about, we also talked about lidocaine. Where this time we're going to finish up by talking about acetaminophen. So if you recall, for NSAIDs, you had arachidonic acid that when exposed to an enzyme, cyclooxygenase 1 or 2, it turns into a series of substances that we call prostaglandins. And those prostaglandins increase pain, increase temperature, and they also increase inflammation. And so by inhibiting the COX enzymes, we can reduce those particular symptoms and reduce pain, reduce fever, and reduce inflammation. Now, that's exactly the same way that acetaminophen works, but instead of acetaminophen inhibiting COX kind of all over the body, and it's only going to affect inside the brain. And because it's inside the brain, it's going to have a fever-reducing effect and a pain-reducing effect, but it will not reduce inflammation. It will also not affect prostaglandins produced in the uterus, which is why acetaminophen doesn't work for menstrual cramps. So, that's really about it for acetaminophen as far as what it does. Now, the big issue with acetaminophen is it's toxic to the liver. So it's broken down in the liver, and the metabolite of acetaminophen is a toxin. And because that toxin is being produced in the liver, there's a potential for liver damage anytime a patient's being given acetaminophen. Now, as long as you keep the dose low enough, there's not going to be a problem. So the rule that we need to know for adults is that the patient can never have more than 4,000 milligrams in a rolling 24-hour window. Roll up the window? What? So what does it mean to have a rolling 24-hour window? Well, what time is it right now? All right, so it is currently 1300. Now, it's really important that you learn how to do military time or hospital time, which is 24-hour time. So basically, you've got 8 in the morning, 9, 10, 11, 12, 13, 14. So in order to figure out what time it is, if you're above 12, you just subtract 12 from it. So 1300 or 13 o'clock is 13 minus 12. It's 1 p.m. So what we mean is 24-hour window between now and 1 o'clock yesterday is a 24-hour window. At the end of our little session today, it'll be about 15:45. And so the rolling 24-hour window, that's 3:45 for those of you who aren't yet fluent in military time. So at 15:45, when we're going to be done with our little session, more or less, the rolling 24-hour window will be anything within the last 24 hours, so up to 3:45 yesterday. So anytime you have a patient who is going to receive acetaminophen, you have to say, okay, what time is it right now? How much acetaminophen has this patient received in the last 24 hours? And if this next dose I'm about to give pushes them above 4,000, then you can't give it. What do you have to do? You have to hold that drug until enough time has passed that when you give that next dose, it's not going to bump them up above this 4,000 window. Now, that in and of itself seems pretty simple, right? Right? So let's give some examples. Now, acetaminophen comes in 2 strengths usually. Now we're talking about adult. Kids with, that's its whole nother calculation. We're not talking about kids in this course. And the number for kids is lower than 4,000. So this is just for adults. You can deal with peds when you get to the peds course. So for adults, the normal dose is 325 milligram tablets. And then there's something called extra strength, which is 500 milligram tablets. Now, they can be gel caps or whatever, no one cares. A pill of some kind. An oral form. Normal dose is 325. Extra strength is 500. So, let's imagine what would happen if we had a regular strength tablet. Acetaminophen is often abbreviated as APAP. So if you have an order for acetaminophen, 325 milligram tablets, 2 tabs, Q 4 hours. So how many acetaminophen tablets can this patient get in a 24-hour period? How do you do the math? I don't know. I'm not good at math. I can't even subtract to figure out military time. How do you do it? All right, so 325, 2 tablets is how much total? 650. So each dose is 650. And the patient can get it every 4 hours. So how many times in 24 hours can they get the dose? 6 times. So 650 times 6 is 3,900. All right, so that is just under the maximum safe dose. So an order that says this, that's a safe order, just under. But it's safe, it can be given on that schedule. But could you give this drug an hour early? If you gave it an hour early, it's going to push them over that 4,000 limit. Now, let's do the same order with the 500s. 2 tabs, Q 4 hours. What do you have there? So double 500 is 1,000 times 6,000. Oh, crap. We're toxic by 50% here. That's no good. So this particular order is unsafe. If you ever see this order, what are you going to do? Excuse me, Dr. Incompetent? Dr. Careless? There's a problem with this order. you don't let an order that's unsafe stand. You've got to question it. It might have just been a typo. Maybe he meant every 6 hours. So let's change this to a safe order now. Well, hopefully safe order. Do that math. So it's 1,000. Every 6 hours is going to give you how many doses per day? 4. So 1,000 times 4, is that safe? All right, so that is safe. So this is just figuring out the max number of doses that a patient can get and an order be safe. Does that make sense? You also have to think about the interaction with other acetaminophen products. So if you remember back to our little talk about Percocet and Lortab, what is Percocet? So it's oxycodone, and that dose of oxycodone is, let's just say it's 5 milligrams. And then it's combined with what? Acetaminophen. And the acetaminophen is almost always 325 milligrams. So if we get an order for this, one tablet, PO, 4 hours, and then we're going to get this extra strength order, PRN. So how many orders do we have right now that include acetaminophen? We have 2 that have acetaminophen. Now, one of them is PRN and one of them is not, right? So the one that is not PRN, that's called routine. You're going to give it whether the patient feels like it or not. If they're asleep, you're going to wake them up and give it to them, I guess. But you're going to give them the drug on a schedule. Does that make sense? They don't have to say, hey, I'm in pain, can I get that? You're just going to give it to them because it's not an as-needed drug. So how much acetaminophen is this patient going to get in a 24-hour period on that Percocet dose? 325, 1 tablet. How many times? 6. So what's 325 times 6? Say it again. 1950. So the patient can, this is a safe order as far as the acetaminophen itself goes. But how much can they get max for this one? 4,000, right. So if you can't give the max of this and this at the same time because that would make the patient go to 5950 and that's too high. So you're going to have a question or more on your test where you're in this situation where you've got a drug that's a combination, Percocet, Lortab, Vicodin, and you have an acetaminophen order that's PRN. And so then you'll have a medical administration record that says the patient received this drug at this time, this drug at that time, this drug at that time. The time is currently X. The patient is asking for pain medication. What can you give them? And so then you're going to have to figure out what you should be giving this patient. Does that make sense? Is it a question there? No?
Yes.
Yes.
So part of inflammation right now, or that we moved on?
No, we are in pain.
We're in pain.
Yes.
Okay. Sorry. Thank you.
All right. So now we need to learn something about hospitals and how they typically give medications. So if you're giving medications every 4 hours, what do you think would be a good schedule to give them? Well, what? 8 o'clock? 12 o'clock? 16 o'clock? 20 o'clock? 24 o'clock? That's actually called 0000. Yeah. So 0000 o'clock, then 4 o'clock in the morning, and that puts you back to 8 o'clock again. So would be a typical every 4 hours schedule. What about an every 6 hour schedule? Start at 8. What's 8 times 6 plus 6? 1400. No? All right, so what's 6 plus 8?
12. No, 14. 14.
I was right. Dr. Cox, you're always right. All right, so 1400 o'clock, and then 8 hours later, sorry, 6 hours later, 20, and then 6 more hours later, 2 in the morning. That doesn't sound like a very good schedule. All right, why don't we start at midnight? Because the patient, midnight, 8 hours or 6 hours later is going to be 6 in the morning. Is that better? And then 6 hours later it'll be 12, and then 6 hours later it'll be 1800 o'clock. Is that a better sounding schedule to you? Okay, and you might have to wake the patient up to give them their 12 o'clock meds, but at least you're not waking them up at 4 in the morning or 2 in the morning, right? So what you'll probably end up seeing is something like that. So the patient's going to get Percocet on the schedule at 6 o'clock, 12 o'clock, and then you would expect them to get the next one at 1800 o'clock. Okay, you don't actually say the o'clock in the 1800. All right, so 1800. Does that make sense? Now, you're also going to be able to give acetaminophen every... Oh, so you know what? It helps if I actually write down the order that I'm supposed to give. Huh? So your perk, I originally said that was every 4 hours, right? Okay. I did say 6?
Yeah.
Oh, what do I know?
You said the acetaminophen as needed every 6 hours. That one tablet oral over.
All right. Let's try writing again. Percocet. 1 tablet. PO. Q, 6 hours. Are you sure? All right, so for Q 4 hours, we got to redo this one. All right. So we're going to start it at 800. They're getting their perk again. Then they get their perk at 1600. And then they got it again at 2000. And then last night they got it in the middle of the night at 100. And then at 4 in the morning. What? Oh. Gotcha. All right. So this is what you would expect to see over the course of a day. Midnight, 4 o'clock, 8 o'clock, 12 o'clock, 4 o'clock, 8 o'clock again. Does that make sense? All right. So then let's say that your patient asked for acetaminophen right here. And you gave them 1,000 acetaminophen. Okay? That doesn't look good at all. Hold on. In order for this to make sense for you, don't worry, it's the same difference. Because I was actually putting you ahead of time. Nursing students can't handle change. All right. So, the current time is 13:10. 1200, they got the perk. At 10 o'clock, they got APAP. At 8 o'clock, they got perk. At, yeah. I'm running out of space. Okay, whew, I made it. So, if it's currently 1310, when do you have to look back toward? 1310 yesterday. So are there any doses that would have been given before 1310 up there for the Percocet? Because the dose before this dose would have been 12 o'clock, and that's past our 24-hour window. So we only have to look up through the last dose. Now on your test, I'm probably not going to just arbitrarily end it there. I might give you that entire next morning or previous morning, and you'll have to figure out when that window starts and stops. Does that make sense? Okay. So, how much acetaminophen has this patient received in the last 24-hour window? I don't know. All right, so we already know that they got 6 times 325. And what was that number? 1950. So we know that they've gotten 1950 of Percocet acetaminophen. And then how many times have they gotten? They got it once. And that's how much? 1,000. All right, so the patient right now is saying, I'm in pain, I want some pain meds. So you have 2 options. Can you give them another Percocet? Are you sure?
No. Right now?
No, it's 1310. They just got it an hour ago. Sorry, not time yet. Can you give them acetaminophen? Has it been long enough? Yeah. If we give them that 1,000, will it push them above 4,000? So, they've already had this. If you add another one in there, will it push them above? No. So can you safely give them acetaminophen in this case? So the right answer for this particular question would be yes, give them the acetaminophen. Now, what happens if this acetaminophen was not administered there, it was administered here? Now what would happen? Is it safe to give?
No. It's safe to give. Well, it's safe to give. Oh, it's a PRN. Yeah. No, it's not. It's Q6, right?
Yeah.
So no, you can't.
Yeah, so that APAP, I remember I told you I should write this down. That APAP 500, 2 tabs, PO, Q6 hours. So even though it's safe in the sense that if you add it up, it's going to be under 4,000, it hasn't been 6 hours yet, so you can't give it. Does that make sense? Okay. So you've got to look at 2 things when you're giving acetaminophen. One is it time for the next dose yet? And then the next question is it going to push them above the maximum safe dose of 4,000? Does that make sense? You can expect, you're going to do this a lot when you go into nursing, and so you can expect a couple questions on your test about this. Any questions about that? All right. I think we did talk about lidocaine last time, right? Blocks the sodium channels. Did we talk about that? Lidocaine, yes. Cool cats, nerds. Yes, I did talk about that. Okay. Through the mists of time, I can remember. All right, so at this time, we're done with the pain meds. Well, there's one more I guess we should just mention, which is, what's it called? You fall apart. Yeah, we'll talk about it later. Not a big deal. So at this point, let's talk about addiction just ever so briefly and pain management in general. So there's basically 2 approaches that we can use to giving pain medication. One is PRN. Now, what's the problem with PRN medications and pain management?
They feel the pain before.
Okay. So you're always chasing the pain, as we call it. So the patient's never in a state where there's adequate pain control because they're either feeling okay or they're not. And they have to wait until they're not before they get the next dose. Some patients are not very good about asking for pain medication. And we haven't talked about this yet, but one of the really important things in terms of recovery is the ability to move around and breathe. Let's imagine for a moment that someone cut open your guts. So you had abdominal surgery. And sometimes what they do is they give you what's called the Mercedes incision. So Mercedes symbol looks like this. And they cut you. Now, and this mean old nurse comes in and she's like, I want you to take big breaths. And you're like, I was split open. Did you see these? They put metal staples into me. I can't breathe. And so they're trying to breathe without moving because it hurts so bad. Guess what that does to a patient? Oh, wait, you actually know because you've had health assessment on this topic already. What happens when a person doesn't breathe enough? What's it called? The A word. Atelectasis. So their little alveoli collapse, and then that can lead to pneumonia. So if your patient doesn't feel comfortable enough to breathe, that can lead to respiratory complications. We also want to get that patient up and walking the very first day post-op, and if they are hurting too much, it's going to be harder for them to do that. So we want to maintain good pain control so that our patients are more likely to move around, which will also reduce their risk of DVTs, which we haven't talked about that either yet, but it'll reduce the risk of clots. It'll also reduce the risk of post-op pneumonia, and it will help them be able to move around, which will help with their recovery. Also help with their bowel movements too, because when we're giving them all of these opioids for pain management, well, you know, it's gonna, haven't pooed in a week yet. So it's extremely important that we maintain good pain control for post-op patients. We can't just let them wait until they can't stand it anymore and then ask for pain medication. So what the more recent trend has been is we're going to give the patient a scheduled dose of an analgesic, and then we will give a PRN for what we call breakthrough pain. So this example that we just had up here, where they're getting Percocet every 6 hours, every 4 hours, whether they ask for it or not, that would be your routine. And then when the Percocet itself isn't enough, then we add in extra acetaminophen. So that is a scheduled dose plus a breakthrough med. So if you want to conceptualize it on a graph, the old school way is we wait until you tell me you're in pain. So this would be considered the pain threshold. When the drug is below the pain, you feel pain or more pain, and when it's above here, you become toxic. So the old way of doing it is we'd wait till you said, oh, I can't stand it, I need some pain. We give you a big old dose, and you go up here, and then you come back down here. So what's the problem? A lot of the time you're in pain, and a lot of time you're over-medicated. Well, that's not the best way to be. So if we give you a more routine drug, and you could try and keep the patient in this range right there. Does that make sense? And then every now and then, they're going to dip down into here, and then you give them the PRN medication. And then there's an even more sophisticated way of doing it, which ideally would end up looking like this. So there's very little variation, and they have kind of a steady state, not too much drug to give them lots of adverse effects, but enough to keep them out of the pain. And this line in the middle there, that's the goal of what's called PCA, patient-controlled analgesia. Now, PCA has two components. There's a steady state, or called a basal rate. So what does the word basal mean? And it's not an herb. So it comes from the root word base. So there's a baseline dose. And then there's also a patient-controlled dose. And the patient-controlled dose, there's a little button that's attached to the pump, and when the patient pushes it, they get a little dose of, Now, these are usually on a lockout. So the patient pushes it, and no matter how many times they push it again, they're not getting more drug until a certain amount of time has passed. But the amount of drug they're getting is very tiny. So it's not enough to last for 30 minutes necessarily. Maybe it's only 7 minutes. A lot of times it's a 7-minute lockout. Now, if you have a patient who's like this, what does that tell you? The base rate is not high enough. They're in so much pain that all they're doing is waiting for the thing to work again. please work, please work, please work. Yeah. Yeah. If you see someone rocking in pain, that's usually a sign that they're not feeling very good. So what we want to do in that case is call the physician and ask if they can raise the base rate. Does that make sense? Before you call them, what key piece of information should you have to tell them? A pain scale is a great one, except that you've visibly shown them they're not. Yeah. What's even more important? What kind of medication are they getting in this PCA? An opioid. So you would want to tell the physician what their respirations are. Because it doesn't matter if they're in a lot of pain and pushing the thing that much. If the respiratory rate is 6, we're not raising it. If the respiratory rate is 26, yeah, okay, let's go ahead and raise the dose. Does that make sense? One of the most embarrassing things ever is when you call the doctor for something. Hi, doctor, this patient's pain is out of control. They say it's 10 out of 10, even pushing the thing all the time. They're pushing it constantly, waiting for the thing to work out. Can we raise the dose to their base rate? Sure, what's their breathing rate? Hold on. Yeah. Excuse me, doctor, this patient is short of breath, and what do their lungs sound like? Hold on. Yeah, right? You laugh now, but you'd be surprised how often it happens. So before you call the doctor, and this goes for your tests also, sometimes you'll hear, call the doctor is never the right answer. That's not true. Sometimes call the doctor is the right answer. But it can only be the right answer if there's nothing else you should have done first. That's a potential answer. So if your patient's short of breath, and one of the answers is listen to their lungs, well, you got to do that before you call the doctor. Does that make sense? If the patient's pain is out of control and you want to call the doctor, well, if assess the respiratory rate is an option, you need to do that first. Does that make sense? Okay. Well, now, if your patient's on acetaminophen only, but that's not so important. But if they're on an opioid at all, especially if you're asking them to raise the dose of opioid, you need to know that respiratory rate. So the PCA has a basal rate, and then they have the patient-controlled part that's on top of it. So the idea is to give them a very small little range of therapeutic drug, and they occasionally go a little up, rather than these really big swings. So that is the direction that we've been moving for at least the last 25 years in terms of pain control. All right, so when I did our initial addiction lectures, it was before spring break, and I hadn't had enough time to truly update my lectures. Now, the amount of addiction research is basically doubling about every 6 months to every year. And so the lectures that I'd given, although they were up to date a year or two ago, they're not as up to date now as they were. And so over spring break, I spent a lot of time looking at more recent addiction models. I've been mentioning them in class, but never had them fully integrated into the lecture. So what we're going to do right now is we're going to fully integrate the newer addiction model into the lecture. So everything that we talked about at the beginning is still the same in terms of what addiction is and isn't. So it's not tolerance, it's not physiological dependence, it's not withdrawal syndrome, and it's not even psychological dependence, whatever that means. All of that stuff is still about the same. Now, one of the original addiction definitions is that addiction is doing drugs even though they cause negative effects in your life. So when you take that sort of definition, you've already defined right into the definition drugs. But we all know that people can have addictive behaviors that are destructive to their life that have nothing to do with drugs. And so our traditional model of addiction as a disease caused by drugs that impact dopamine, well, that doesn't really fit in terms of gambling, pornography addictions, sex addictions, food addictions. None of that really fits into that drug model. And so the broader definition that we're going to talk about today, the broader model that we're going to talk about today is able to explain those things in addition to drugs. So let's just talk really quickly about the traditional model that we thought about. So we all know that our brains adapt to drugs. I mean, that seems pretty self-explanatory. And even within just regular psychotropic drugs like an antidepressant, well, you take an antidepressant at a low dose, and then after about 2 weeks, you have to raise the dose. And then after about 2 weeks after that, you may need to raise the dose again. Over time, your brain will adapt and you'll probably need an even higher dose. If you come off of that antidepressant, suddenly, you're going to go into some serious withdrawal syndrome. No one ever says, oh, I'm addicted to my antidepressant. And yet, it displays all of those hallmarks that are sometimes associated with addiction, and it's not really addiction. So tolerance and withdrawal syndrome are not addiction. But they're evidence that your brain is adapting to the drug. Does that make sense? So the idea, the model, was that when we do something really enjoyable, we get a little hit of dopamine. And we talked about dopamine is the kind of the reward for accomplishing goals. How many of you like to make lists to do things? And the very first thing you do is you put 4 things on there that you've already accomplished. So you can cross them off right away. I feel good about myself already. And then, how many of you say, all right, this is the hardest thing on the list and it's going to take me the most amount of time, let me do that first? Or you say, ooh, let me do these short little ones first so I can feel like I'm doing something. And so as we work towards a goal, we get little hits of dopamine that make us feel good and reinforce doing the goal. Right. And that is one of the reasons why social media can be addictive, because you get this little hit of dopamine every time you post something. Oh, look, I got a like. Oh, look, someone, yeah, and I got an interaction. And so that's a little goal that you can work towards. One of the things that sometimes happens is when you have reached a big goal and you have no more goal left, now you have nothing to work towards, so people sometimes feel depressed. This is very common in athletes who get to the height of whatever it is. So maybe it's Olympic gold medal. What do you do the day after you win an Olympic gold medal? You got your life's purpose is met now. What do you have left? A lot of times they're depressed the day after they win the gold medal. So that's one of the great things about Tom Brady. Now that he's won 6 Super Bowls, you know, anyone else who comes behind him, when you win one Super Bowl, well, you got 5 more to go before you're as good as Brady. So everyone in the world now who is a football player doesn't have to feel that sense of purposelessness until they get to their 7th win of the Super Bowl. Now, it's a great, great service that he performed for the world, I think. But anyway, so dopamine is what we get when we accomplish goals, and it makes us feel good. Now, how many of you have ever, one day you're doing great things, you got all these things are coming together, you're like, this is great, and then something happens that you receive some news, and that goal just kind of like progress towards the goal goes away. And how do you feel? Like, forget it. I'm not going to do anything. I'm not even going to try tomorrow. I'm just done. You just feel horrible. And that's what happens when we don't get the dopamine. You just feel like you don't even want to get out of bed. There's no purpose. So that dopamine helps to give us purpose, give us direction, and then it's the reward for accomplishing those goals. Does that make sense? So, what happens when you take drugs that can give you much higher levels of dopamine? The idea is that you have this really spike up. So let's say that this would be your ordinary max dopamine level you can do, but think of the most fun thing you can do in the entire world. The most exciting thing you can do. Skydiving, sex, whatever. And the max you can get is this. Now, when you do drugs, you go higher than that. Your brain's like, whoa, I got to do that some more. But the more you do it, your brain goes, you know what, maybe it's dangerous to have dopamine up here. Let's build a structure that will make it so that it's harder for the dopamine to get through. So you build a little barrier. So now when you do drugs, you don't get dopamine up here. I mean, that much dopamine can be stimulated, but in your brain, your brain is only getting this much dopamine because of this barrier. Does that make sense? So now you come off the drug and your dopamine level's down here, but you've got this barrier, your brain can't even detect the dopamine. So now when you come off the drug, it's not that you don't feel good, it's that you feel bad. So that depressive state you felt like when you were defeated, when you didn't get the goal that you were like blocked from your goal, That's how a person feels all the time. They need the drug not to feel good. They need the drug to not feel bad. And that is kind of the dopamine model of addiction. Now, guess what? Those changes to your brain are not permanent. Your brain changed. We call that plasticity of the brain. Your brain changed in response to the excess dopamine from the drug. And guess what happens 6 months to a year after you stop the drug? Your brain plasticity goes right back, and you can actually have a normal brain again. So it's not that once addicted, because of the structure of the brain, always addicted. There's something else going on that has to be there for addiction to occur. And so that's what we're going to talk about now, is that newer model of addiction. So the newer model is three main components. So the first one is a deep learning pattern. And this is pretty consistent with what we've already said, that addiction is a learned pattern of behavior. So going back to the idea we talked about in the original lecture, that if you have a baby who's born to someone who's been doing crack cocaine, that little baby has a physiological response to cocaine, but it's not addicted to cocaine. It doesn't even know what cocaine is. It has no idea that if I do this behavior, I'll feel this way. It's just in withdrawal syndrome. Same as if a person was on too many opioids. Well, addicted. Sorry, never mind. Wrong. Bad example. If a person was on too many selective serotonin reuptake inhibitors, antidepressant, and they come off of that suddenly, they're going to experience withdrawal syndrome just like a person who's coming off of the cocaine does. So that baby has no established pattern of behavior, therefore they can't truly be addicted. So where does addiction come from? It comes from a learning process. So now, this is where dopamine is part of this. So we have this brain that goes, that's an interesting idea. Maybe I want that. And so then there's conversations between different parts of your brain that go, hey, yeah, that's worth going after. Oh, yeah? Maybe it is worth going after. Boop, little bot of dopamine. Oh, yeah, pursue that now. And so now you get this drive toward getting that thing. So how many of you have ever had this experience? You can just put it right there for now, thanks. So how many of you have ever had this experience where you hadn't even thought of something, and then you see it, you're like, oh, I'd like that. And then all of a sudden, that's all you can think about. I have to get it. I have to get it. I want to get it. How do I get it? And you start researching it, and you're looking for it. You're like, and you have this sudden desire for this thing that you didn't even know about before. Well, that's that little process in your brain going back and forth with, I want this. Oh, yeah, well, go get that. Well, here, have some dopamine in response to pursuing that item. And so we have a learning behavior going on in that regards. Now, when it comes to something that we know that the things that we're addicted to are not good, right? So I'm going to use donuts as the example. So let's say for a moment, you're like, you know what? I love donuts, but I know that they're not really good for, Okay, so I have no intention of eating donuts today. You didn't even think about donuts. It wasn't even on your radar. You got my calories in my fitness pal. I've got a healthy breakfast already. I've got my lunch figured out. I already know what dessert I'm having for dinner, and I'm going to be under my daily calories. I am the weight loss queen, or king, as the case may be. So, but you go into work, and someone's got donuts. And they're not just any donuts. They're Jupiter donuts. And you're like, oh, Jupiter donuts. But now you're going, there's donuts in that room. And your mind is like, yeah, you could have donuts. You could have the donuts, I gotta get the donuts. So every day, the rest of that day, you're going in, you're walking by the office that has the donuts in it, you're like, and you spent the whole day going, donuts. Now, you finally get to the point where you're like, I'm bringing in some of the next thing, but hey, whatever. So someone then comes to the end of the day and they give you the donut. You're like, you smelled it. Once you smelled it, it was over. You had to eat it, right? So then you eat the donut. Now, How did that donut taste?
Delicious.
Oh, it was good. How'd that make you feel? It made you feel good, right? Oh, so delicious. You know what? Give me another one. Now, so the donut itself is good, and you knew it was good, and that's why you had to avoid it, because you knew you shouldn't be eating that, not because you already had your own calories. But you ate it. So you enjoyed the donut, but now how do you feel? Now you feel guilty. And when you feel guilty, you feel bad. And when you feel bad, what do you want to do? Something that makes you feel good. And you know what made you feel good just a minute ago? Eating a donut. So you know what? Now you eat a second donut. And now you feel even guiltier. So now what do? Maybe you go for a third. Okay. And you get the idea, right? How many of you have ever had that happen? Now, losing weight on a diet isn't really that hard. You know what's really hard? Keeping the weight off. And research has shown time and time again that this is what happens. A person will have something they shouldn't. And not necessarily that they shouldn't in the broad sense of it, but in the sense that it was above their calories for the day or wasn't on their diet, whatever, they broke their rule. And once they do that, they feel guilty. So instead of just saying, okay, well, that was fun, I enjoyed that, yes, that was great, but now I'm gonna go back to my diet, they double down or triple down or quadruple down. And so instead of having 600 extra calories for the day, they end up having 3,000 extra calories for the day. And once they do that day, then it's so much harder to get back on the diet the next day, and they just spiral down until they regain all their weight. Whereas if they had just said, man, that donut, that was probably 600 calories, but man, it was good. All right, back on the diet now. They wouldn't gain the extra weight because they would be able to maintain their stuff. So this particular idea here of this deep learning pattern that involves guilt and then making yourself good by doing the thing that made you feel bad in the first place is, very much, it helps to explain a lot of addictive behaviors that are not necessarily drug behaviors. So that's the first component, is the deep learning pattern. The second aspect of the model is what we might call a decreased sense of future and an urgent now. Now, for those of you who had me in FYE, we talked about the marshmallow experiment. You guys remember what that is? So in the marshmallow experiment, what you do is you take a child and you put them in a room by themselves and you give them a marshmallow. And you say, hey kid, if you don't eat that marshmallow for 5 minutes, I'll give you a second marshmallow. And then you leave and you record what the kid does. And the kid's like studying it, smelling it, kiss it, lick it, take a little bite out of it, eat that marshmallow. What they've shown is that kids who can successfully resist eating the marshmallow for 5 minutes so that they can get a second marshmallow have the kind of self-control that it takes to be successful in life even 20 years later. Even at age 4, the ability to delay gratification for 5 minutes is predictive of success later in life. Because what is success in life about? Saying no to all the stupid ideas that are really fun right now so that you can be a little more successful in the future. And that was our whole thing about the diet with the donuts. It's not that you can't have a donut. It's not that a donut doesn't taste good. It's not that a donut is bad per se, but it didn't fit into your plan for that day, which was to do a longer term goal of be more fit or lose weight or keep the weight off. And so because of that, when you give in to the donut, what you're saying is my need to feel good now is more important than my future life. And within the context of a single donut, it's kind of silly. But when you think about it in terms of drugs or gambling or pornography, it makes a lot of sense that your need to have this little bit of pleasure right now is more important than your life with your wife in the future, is more important than your kids, is more important than your entire family's well-being. Especially with gambling, you have people who spend their entire life fortune, sometimes hundreds of thousands of dollars. Their wives and their kids don't even know until creditors start calling, asking to collect on debts. And you're like, well, what do you mean the electricity bill hasn't been paid? We have like tons of money in the bank. What happened? Yeah. So that's the idea of that increased sense of urgency versus a decreased sense of future. So it's an inability to look beyond right now to see the future and then make choices for your future. If you listen to someone like Jordan Peterson, he talks about that there's not just a single you, there's multiple yous. And you are actually made up of multiple subparts. So there's a part of you that just wants something now. There's a part of you that wants to plan for the future. And the part of you that those two things are competing with each other right now. And so when you choose the things that will give you a better life in the future, what you're actually doing is you're not acting on your own behalf now. You're acting on the behalf of the you that you'll become in the future. Does that make sense? Kind of cool idea. But that's the idea with that second component. And then the third component is called executive fatigue. Now, what's an executive? It's the adjective of what verb? Execute. So the idea implicit in this is that there's multiple things you could do, but what you actually do is what's being executed. In the military, you typically have, like say on a ship, you would have the captain of the ship. And they're in charge of making decisions, but they actually do the work, or they just have other people to do it. They have other people to do it. So they're giving orders, and then other people are carrying out those orders. And there's usually a person who's just underneath the captain called the executive officer. So when the captain says, all right, we need to go to this place at this speed, the executive officer is going to go around and make sure that that happens. So the executive officer is in charge of executing the orders. Does that make sense? So the idea of executive fatigue is the idea of being in charge of these competing personalities that you have inside of you, that this one wants to be lazy, this one wants to eat, this one wants to sleep, and this one wants to be successful in life. And which of those personalities is going to win in this given moment? So the part of your brain that's responsible for choosing which one of those personalities gets to win and execute their orders, that's what we mean by executive control or executive function. So an executive fatigue is the idea that you can only make so many choices. And eventually you get tired and you let the things, you just let your self-control go and do things you know are not necessarily in your best interest because you just got tired of making decisions. So you actually see this sort of thing reflected in some very successful people like Steve Jobs. They decided, I'm going to eat the same thing every day and I'm going to wear the same clothes every day because those are two less choices that I have to make in life. And that will allow me to have more brain power to make decisions in my business. And so going back to that donut idea, what point did you have to say, how often did you have to say no to those donuts? You had to say no the moment you walked in the door. You had to say no every time you walked by the office. You had to say no when you saw your coworker eating one of them. You had to say no when someone brought them to you. You had to say no when you smelled it. At some point in the day, you just got tired of saying no. You know, they've done studies where they take people, some of these studies aren't necessarily, the most rigorous, but they take people and they say, okay, you can have, here's a bowl of cookies, and here's a bowl of radishes. You can eat as many cookies as you want, but you can't have any radishes. Oh, okay. These are hungry people. They haven't eaten in 8 hours. You can have as many cookies as you want, no radishes. And so they let them eat whatever they want, and then they give them some tests. And then they do the opposite, where they say, here's a bowl of cookies, here's a bowl of radishes. You can eat as many radishes as you want, but you can't have cookies. And they give them the same series of little tests. And the people who are allowed to eat the cookies do better than the people who don't. And the idea behind that was that it takes mental energy to say no. Don't eat the cookies. And that will reduce your ability to think and perform later on. How many of you have ever been in a meeting where they had food present and you're like, well, I don't want to eat the food because because I've already eaten and it's not my, and the food is sitting right in front of you. And the entire meeting, what are you doing? What happens about 3/4 of the way through the meeting? Nah, forget it, I'm gonna have the, right? And that is executive fatigue. Now, knowing that, one of the very, very important things we should do for patients who have addiction is to help them with executive fatigue. They need to change their environment. If you know that one of the things that gets you in the mood to do whatever it is you do, say drink alcohol, being around other people who drink alcohol, if that's one of your things, well, maybe you should be around people who don't drink alcohol. Everyone has slightly different triggers. Everyone is slightly different. No one is exactly alike. And teaching people how to avoid their own things are very important. Now, part of the reason this is also important is that if you look at these things, which one of these three things involves a disease process? Oh, none of them, right. Because addiction isn't a disease. But Dr. Heyman, that's the first thing you learn in AA. Well, AA is an abject failure. 95% of the people who go through AA, guess what? They're not helped. Now, the 5% that do get helped, you know what they say? AA saved my life. This is the best thing ever. But what you're hearing from is a very small minority. Research has actually shown that believing that addiction is a disease is a risk factor for failing. The idea that, well, you're not in charge of your choices, you don't have a choice, this is a disease that has you, means that you don't have responsibility. So when you do fail, when you do relapse, well, it's just the disease, it's not me. Does that make sense? So it's extremely important that we understand that although we've been taught most of our lives that addiction is a disease, is not true. Now, it doesn't mean that a person is in complete control. They do need help. But what they don't need is treatment. What they need to do is to have a reason to make better choices. So there's newer models of recovery. Now, in the United States, the vast majority of treatment centers and recovery centers are 12-step based, which is based off the AA model, which says that addiction is a disease. So almost all of the money to be made in rehab is in treating it as a disease. But when you don't treat it as a disease, when you use these newer models, you actually have much better success in treating addiction. The other thing is that there are, just in the case of opioid addiction itself, there are what are called partial agonist-antagonist. So this is a drug that it does stimulate opioid receptors, but it also blocks them at the same time so that another drug can't also activate them. So it's kind of like a Narcan that has a very small amount of opioid effect as well. One of them is called buprenorphine. And patients in buprenorphine clinics can be extremely successful in their treatment. Remember we talked about earlier that when it comes to opioids, when you take your Percocet, you don't like the way it makes you feel, it's going to be very difficult for you to become addicted. On the other hand, there are some people in life that when they take the opioid for the first time, they take Percocet, they're like, I feel amazing. This is the best thing I've ever done. That person is very likely to become addicted. But again, it all comes back to these three things. So we're treating addiction as though it's something that's inevitable, it's a disease, and we're allowing people to not take responsibility for themselves by using that model. Now, all of that is to say that if you're, I'll put up some resources to books and articles that support what I've been telling you right now, so you don't have to just take my word for it. But there are very successful physicians and counselors who treat addiction, not treating it as a disease, but treating it as choices a person makes who has the ability to change. And doing that, I think, is a much more humane way of practicing because it preserves our human dignity, and it also preserves one of the most important things that makes us human, which is our ability to choose. And we should also say it's a God-given gift that God gave us the ability to choose. If you can't choose, are you truly human? So all of that to say, addiction isn't a disease. All right, at this time we're going to go back and we're going to talk about NSAIDs again, just ever so briefly, because some of you expressed that you were surprised how many NSAIDs there were on the test. So remember that the test is going to be about 60-ish questions, and half of them will be on pain management, and then about half of those will be on drugs. So the big categories of drugs under pain management is anesthetics. There'll probably only be like 2 or 3 questions on that. Opioids, you can probably expect about half-ish the questions on that. And then NSAIDs and acetaminophen. So say acetaminophen has 3 to 4 questions, well that leaves about 10. Nah, it leaves about 8 questions for NSAIDs. And you're going, but there's only 2 slides on it, so there's only gonna be like 2 questions. So that can be a little bit confusing. So that can be a little bit confusing to students. So let's just recap NSAIDs real quick like. So we have arachidonic acid. Arachidonic acid is converted into prostaglandins by enzymes. 2 of the enzymes, the 2 we need to know for right now, is COX-1 and COX-2. So COX-1, COX-2. Now, which of those 2 leads to inflammation under ordinary circumstances? Does COX-1 lead to inflammatory prostaglandins, or does COX-2 lead to inflammatory prostaglandins? COX-2. So when we give NSAIDs for the purposes of reducing inflammation, reducing fever, and reducing pain, which of these 2 pathways are we wanting to target? We're wanting to inhibit COX-2. So COX-2 is almost all, when we inhibit COX-2, that's almost all therapeutic effect. Does that make sense? Now, when we inhibit COX-1, what are we inhibiting? We're inhibiting gastric mucus. Is that an adverse effect or a therapeutic effect? That's an adverse effect. When we inhibit renal perfusion, is that adverse or therapeutic? Adverse. When we inhibit, clotting, is that adverse or therapeutic? Well, that could actually be either, right? Now, there's only one drug that is used therapeutically to reduce clotting. What is that? Aspirin. So for everything else, it's going to be adverse. Does that make sense? And then the macrophage function, that kind of goes along with the therapeutic over here, but you can pretty much ignore it. The last one would be the uterine contractions, and this one could be therapeutic, right? If you're treating menstrual cramps. But in the hospital system, in the healthcare system, the vast majority of people who are taking NSAIDs are not taking them for menstrual cramps. And even a person who does take them for menstrual cramps, how often are they taking them? 2 to 3 days, once a month, right? It's not like they're going to be taking these all the time. The vast majority of reasons why people take NSAIDs is for this over here. So when you inhibit COX-1, what are you primarily getting? Adverse effects. When you inhibit COX-2, what are you primarily getting? Therapeutic effects. Now, there's only one truly selective COX-2 inhibitor on the market, and that one is Celebrex. So Celebrex does only COX-2, celecoxib. All of the others inhibit both, so we draw them in the middle. Ibuprofen, naproxen, ketorolac, and aspirin. Now, there's a whole bunch of others with varying degrees of selectivity, but we're not going to talk about those in this course. So when you become a nurse practitioner, then we'll talk about that. But for now, just these 4 plus Celebrex are what you need to know. So on the test, you might need to know, what's producing adverse effect, what's producing therapeutic effect, and which of these are selective or not selective. Any questions about that little NSAID supplement? All right. Now, there's something else that we need to supplement you guys didn't mention, but I'm going to mention, and that is IV acetaminophen. So there has been a growing trend towards using IV acetaminophen, and I've got a little article about it on the test guide that you can read. But what's really important is the way that you answer the question. So when you answer the question, why are we doing this? Well, you have to compare it to something else. So if you compare IV acetaminophen to PO acetaminophen, that's one thing. If you're comparing IV acetaminophen to opioids, that's another thing. And you need to make it clear in your answer. So sometimes students will answer, well, it's safer. Safer than what? And what's the other question that has to be answered in safer? Why? So safer than what? And how is it safer, or why is it safer? So let's just go over a couple of the advantages of IV acetaminophen. So the very first one is that when compared to PO acetaminophen, it doesn't go through the liver first. So there's no first pass effect. Now, why is that important? Okay, so why does a person become toxic in the first place? It's the accumulation of metabolite in the liver. So if the very, very first place that all of the acetaminophen goes when it gets absorbed is to your liver, you're giving a whole bunch to your liver first, and then it goes into the systemic circulation. When you give it IV, it doesn't have that first pass effect, so it's going to your entire body first, and then a little bit by little bit is going towards your liver. So you don't get this giant rush into your liver at first. That makes it a little bit safer for your liver than PO. Now, you still have to obey or follow the 4,000 milligram rule. You can't get away from that. But it is a little bit safer for your liver. Now, when compared to opioids, there are several reasons why we can do that. So the very first one is that you can use it during surgery. Now, sometimes students will say, well, you can use it during surgery. Well, yeah, you can also use opioids during surgery too, but what's the issue? When you give a patient an opioid during surgery, what does it do to their waking up later? Makes it take longer. Okay, so you can give it during surgery without prolonging the post-anesthesia process. Does that make sense? Second one, well, less addictive. Third one is it is safer in children. Now, opioids in children can be given safely. However, there is an increased risk of respiratory depression when compared to adults. They're more likely to experience respiratory depression, which is more likely to be dangerous to them. When you give acetaminophen instead, you avoid that issue. So those are some of the big reasons why we're moving towards IV acetaminophen. A couple years back, like about 15 to 20 years ago, there was a really big push to assess and treat pain. And it became one of the big standards of care. How well are you assessing and treating pain? Well, when you assess pain and you're treating it more aggressively, what are you going to do? give more opioids. And now we're like, opioid epidemic, what are we going to do? Let's not give opioids. And well, here you've got something that can be given instead. So on your test, you're going to have to know why we're moving towards IV acetaminophen. Note that IV ketorolac can also be used in place of acetaminophen or in combination with acetaminophen. So it's not like IV acetaminophen is the only non-opioid tool in our that utility belt. Sorry, in our arsenal.